me the car while driving it. And so I think knowing that we need to feed you the information that you can digest and act upon, that's our job, that's our role. And then funding, I think funding is always in the front of our minds and at the back of our minds, and figuring out how do we fund and how do we find a match where appropriate and what programs aren't working and how can you transfer that funding into something that's appropriate for those individuals that need additional support. Regulatory obstacles, I think getting to know the regulatory landscape, figuring out what the rules of the road are, and making sure that there is an open dialogue with everyone concerned will overcome that barrier as well.
Okay, we got a question here. Sam, as you're well, she finished this slide. You want to press on her? Okay, go ahead.
I'm just going to conclude here. A lot of our clients have come to us and talked to us about 1332 waivers. What can we do there? Can we get a 1115 waiver? And our approach will certainly take into account all of the various waiver opportunities that exist to implement the programs. But we want to stress that our approach here is going to be to help develop options first and determine the best possible solutions, and then determine the best way that you as a state can proceed to implement those. And so we don't want to go into this with any preconceived idea that you're going to be changing 1115 or rewriting a new waiver or any of that. It's going to all develop. And I'll just go to the final slide then. And there's so many questions that you asked in the RFP, and they're all very good and very detailed, and we certainly couldn't do justice to those in the time we had here. But if you think back to the staffing chart that we had, I just want to remind you of how we propose to do all this. We do have a project director, we have a project manager, we have 2 teams of individuals. We're going to have a team leader who's responsible for looking at the insurance option, and we're going to have another team leader who's responsible for Medicaid, and then we have a combined staffing pool that will help us do the data analytics, that will do the policy research, and that certainly will talk to one another as we're developing these options, because we don't want to ultimately develop a solution of competing priorities. So bringing all this together, then we will share with you periodically during your task force meetings what our findings are and our recommendations. Obviously hear from you on the direction we're taking and make any mid-course corrections that we need to do. And then ultimately develop our final recommendations and develop the final report by the due date that you specified in the RFP.
All right, thank you very much. And I think, as I mentioned, we had a list with 4 questions on it. I know you touched on the first one, but we'll give you a chance to touch on it again. We'll do those 4, and then we'll take questions from the floor. So at first, I'm going to recognize Representative Meeks to ask the first question.
Thank you, Mr. Chair. And again, so you touched on this. You talked about having hospital CEOs as part of your team. And I think you mentioned too, having like former Medicaid directors, and I think the other consulting firm did as well. So, with that said, can you describe what makes your firm unique in the industry? Maybe because again, these guys have Medicaid people already on their team and everything of that nature. So is there something else that you may not have mentioned that would make your firm unique? And anybody on there can answer that question.
Sure, I'll just start and you can jump in. I mean, I think as I said, I think what makes a team unique for this purpose, for this proposal, first of all, is we brought together 2 very seasoned teams, and we think we can bring you a totally objective overview of solutions and recommendations. And I think by having the 2 consulting firms together and working together, we are going to assure you that we're not going to be giving you a solution that's been right for 12 other states, and we're going to do it here. That's number 1. Number 2, I think just by virtue of the fact that we have been working with some of these states on innovation, and that we have a combined group of individuals representing both providers and payers, that we understand really what's state of the art in terms of innovation, and we can in ourselves be very innovative in our approaches to delivering your services.
We also know your program. I mean, I would tell you, Arkansas runs a good Medicaid program. I've known your prior CFOs, your prior directors. We understand how things have worked here. However, we haven't been a part of developing anything here. Our work has been auditing in nature, consolidating things in nature. I think we can offer you a perspective that Navigant wasn't a part of creating any other things we would analyze. I would Sellers Dorsey, our subcontractor. We bring an objective approach. And we've also had a lot of experience working in the South. And I would tell you that I'm working regularly in Mississippi, Alabama. We're standing up a completely new program, homegrown, hospital-based managed care organizations for the state of Alabama. We've been working in Mississippi for 12 years. We're working in Texas, Georgia, North Carolina, South Carolina, Florida. And I would tell you that I think having the perspective of knowing your legislative agenda, knowing the governor's agenda, knowing the culture that exists not only within the state, within the Medicaid agency, I think will offer us the ability to come in a trusted, respected manner and to expedite results and operational recommendations. That's why we priced it the way we did. We know the program, we know what to expect, and we believe that your leadership within DHS and Medicaid knows what to expect from us.
All right, the second question, Representative Ferguson. Push the yellow button again. This time it was my fault.
Okay. Thank you, Mr. Chairman. This is actually a two-part question. Describe the biggest drivers in escalating healthcare costs, and what specific measures have demonstrated success in changing that cost curve. I think what value-driven reforms do you think have been most effective?
Well, I think, interesting, just this very timely question considering yesterday CMS just published some of the results of the bundling programs as you're doing now in the state. And while there probably were some disappointments in terms of the level of cost savings, we're certainly moving in the right direction. And so I think those initiatives that are those value-based purchasing initiatives that are designed to, first of all, better integrate care have proven to be more effective in reducing costs. And again, it's a gradual slowing of the increase. It's not certainly the level that we would probably all like to see as taxpayers and as buyers of healthcare. And then the second thing is to avoid all of those unnecessary costs that have been incurred within the system. So those initiatives that have been taken to reduce the readmissions to hospitals, to identify bundles of services and create best practices for everyone to follow in terms of payment and delivery are those that have demonstrated some level of success. I think it was probably disappointing as a consumer to learn that in some of the research that just came out recently that even though consumers are now being inundated with a lot of information about the cost of healthcare and they can actually do a better job hopefully of selecting more cost-effective providers, that seems to not have the impact that everybody had hoped. So I think that suggests the need for probably continued better education and continuing to share that information with consumers so we can all make better decisions.
I would add that integrating care, including the behavioral aspect of the physical health, are cost drivers. I think we've underestimated the impact of mental health and physical health. And a lot of those emergency room visits have nothing to do with the chronic illness. It has to do with the social issues and behavioral health issues that exist wherever folks feel that they have a place to live. And so I think that access to care is another big cost driver. You will see people waiting a very long time to be seen for something that was once preventable, that's no longer preventable, and that's at a different stage of illness. And that cost has a big impact on the system.
One of the things you've done that's really interesting is the bundled process, and I think expanding on that would be hugely beneficial. We're seeing states where 50% of the births are cesarean. There's not a medical reason for those births to be cesarean. It's a matter of convenience for the OBGYN for the patient. They don't have transportation, so they schedule a time when someone can drop them off to go to the hospital and have their baby. It's a whole lot cheaper to make sure the transportation is available and have a vaginal birth than it is to pay 5 times as much for a cesarean. The rate of neonatal intensive care units for Medicaid children is off the charts. But what we've seen is, as you start to incentivize providers, they'll offer more efficacious care and drive those costs down. So as was mentioned, the highest cost individuals are those with 2 or more diagnoses, the comorbidity issues. And I'm a pull yourself up by the bootstraps kind of guy. I'm a finance background, MBA. It took me a while to come around to appreciate the behavioral health component and how expensive it can be on the physical health side if you're not also addressing that behavioral health component at the same time. Somebody mentioned the prescription drugs and the fact that it's driving the cost. I would also ask you to work sometime, and if we do the work, I'll take it as a personal challenge and bring it to you, is look at who's writing the prescriptions for the mental health drugs. It's not psychiatrists. It's pediatricians, OBGYNs, and GPs. And I'm not talking about Prozac and Paxil. I'm talking about atypical antipsychotics, some of the most expensive drugs that are being prescribed. And it's a tough thing. The side effects are tough. And the cost is a lot for you. And you've got, pretty soon you're going to have to wrestle with the Hep C drug. You know, that's a crazy expensive drug. But it's a whole lot cheaper than a kidney transplant or dialysis for 6 or 8 years.
You know, we've got a couple more questions, standard questions on the Senate end, but we spent a lot of time talking about what are the cost drivers, what are the problems, but I guess what I would like to hear is, can you point to an example where your firm intervened and implemented some measure that either slowed the rate of increase at least, or changed it to a decrease in cost?
So we have done about 100 of the bundle payment projects for CMS, for Medicare. We have also implemented some, and that's throughout the country. So we have worked with hospitals on developing, hospitals and commercial payers and the development of their bundle payment projects.
So that would be the primary one.
I would say that is, because those have already been proven to now have saved money, and many of those providers, probably more than half of them, have received incentive payments. And so, and for many of those that haven't, we're continuing to work with them to get their savings up to a level that would encourage that.
Okay. Senator Chesterfield, you have the next question. If you have a question about it, Director.
Thank you, Mr. Chair. And good afternoon and welcome to our state. As Vice Chair of Audit, I'm concerned about what your company considers, what constitutes a thorough audit of Arkansas's Medicaid program and the expected results of such an audit.
Thank you, Senator
I
Chesterfield.
know you spoke to it briefly, but I'd like to have you explain.
Well, we would first start by talking with representatives from this committee, from other members of the legislature to find out what you think the issues are. We would do a search of documents before we conducted interviews. We would conduct interviews and listen between the lines. We would take what we learned during those interviews and do further documentary research. We would dig deep. We would look for the connections, tie the dots together. I've found this when I've done assessments and audits that often it's because people in different agencies aren't talking to one another, or they think they're doing what they're supposed to be doing, or they have different priorities. So you want to look beneath that and listen very carefully. I think it's very important to do that in an audit. Document what we find and keep drilling down. I think that, does anyone else want to say anything about that?
Yeah, we've done audits of Medicaid and other state accounts, for example, state employees accounts, and what the team will do to initiate this is to sit down as a group and develop after the interviews and to understand what we're hearing and develop some detailed audit guides. And I'm using the term audit as a review as opposed to we're not CPAs, so we're not doing that kind of audit, but we'll develop some standard protocols for reviews, some audit questions, and continue to document all of our findings as we go through each of those review templates. I think we mentioned in the proposal that it's our approach that we might have multiple people involved in the review so that we're not just relying on one person's interpretation of a particular finding. And the other thing we will do is at the conclusion of each of those reviews, we will review our findings with the individuals with whom we've met to make sure that we can confirm our findings, that we haven't missed something, and continue to socialize those findings around the organization to continue to make sure that we are getting the results that we anticipate, or not necessarily that we anticipate, but that are in response to the particular audit topics that we've identified.
Your legislative auditor is soon to release an audit report. I think that what I understand is there may be some issues in that audit report that have been noted in prior years. There will be an opportunity to improve that, and that goes back to reconciliation of how you're spending the federal government's money. However, when you talk about Medicaid, I would ask you, do you mean the Medicaid agency, or do you mean the plethora of agencies that are spending Medicaid dollars? That's where you've got some problems, is there's very little coordination within your state between the sister agencies, as I call them, and Medicaid. So you've got BD, mental health agent, and others spending Medicaid dollars, but historically the Arkansas Medicaid program has been held at arm's length. As I've talked to folks at Medicaid within your agency, just as we talk about program integrity and its role in a broader context, the Medicaid role, the Medicaid CFO's role, for example, he should be responsible for signing that 64. Right now, the Medicaid office doesn't sign that. That goes up to the Department of Human Services. It doesn't have oftentimes the data, and that's not unusual, but there needs to be a look at how other agencies are spending Medicaid dollars. And I would tell you that the best way to get there is a risk assessment approach. And it's just like we're taking with this as a larger context. Where are the highest dollars and the highest levels of risk? And let's dig into those defined areas that you've also had your A133 audit, you've had your federal funds audit, you've had audits that have been done. I've endured those. I've been audited by CMS, the OIG, the IRS. I've been audited by everybody who possibly audited by. And I used to do those audits. Remember, I was a partner with the National CPA firm for 9 years. So I think what you're looking for is how do you do a retrospective analysis that provides you with the ability to go home at the end of the day and know that those Medicaid funds are being spent in the most efficacious manner and that you're being good stewards of the money while also delivering the highest level of service. And that's part of the process.
That is one of the things I'm looking for, but I'm also looking for legislation that might lead to perhaps putting them all in one place so that they're easier to make. I don't want you to think that we're just talking about leaving the status quo, because if it is, then we're wasting a lot of time here. And so we were charged with this, in this committee, with looking at all of it, the plethora, as you say, of all of it. And it could lead to legislation that would create a more smooth operation. It could lead to changing from one division to another and putting them all in one house. So I don't want you to think that because it's currently set up this way, that this committee is going to have to leave it that way. And if I'm wrong, then I've misread what our charge is, which is to revamp all of it and make it more efficient than it is currently.
But the canvas is that large, I think you have an opportunity to paint a picture that would be much more effective and expedient in how to do the business.
Anybody else?
I think it's important to look at the levels of accountability in the organizations and how they communicate with one another. Having worked in one of the silos of CMS and then transferred to another silo of CMS and then realized the silo I came from was working on the same thing I just got new money for, I understand what you're asking. And I think in state Medicaid offices, you will have programs that serve duplicated populations that are paid differently for the same service. And because they don't talk to one another, nobody knows that you're paying twice for something that is still subpar. And so I think that is something that, you get standard reports from your MNRS vendor. Some of that information should be feeding into that system. Who's looking at those reports? Who's accountable for those costs? So that would be part of what we look at as part of our audit process, is figuring out, what are you doing and what are you charged with in this department, and it's got the same thing that this other department is doing and charged with different money, for the same services, so.
Thank you so very much.
Senator Chesterfield, I just want to respond to your general comment about the type of canvas we're working on. I just want to, I read our charter the same as you read it.
And we've got one more question from Senator Cooper, we've got a couple generic questions, but I just want to give one final clarification on this audit thing, because we've asked it, and I'm sure everyone's going to be asked of it. I see an audit as one of the processes and procedures, and one of looking at the data and saying, of these 216,000, we see no documentation to support eligibility of 24,000, and here's the names of who they are. Or the current Medicaid program, the same sort. I guess that's what I'm asking, is are you including in your proposal that you will be able to provide to the task force that type of result?
Yes, we're only going to look at a random sample, but we will identify in that sample who should be eligible and who should not be on rolls, who is probably given eligibility. So
Don't
that's
say a random sample.
But it's a statistically valid sample. And we would do it at the same level of confidence that the OIG or anybody else would, which it's acceptable under litigation practices, which is a 95% confidence interval with a 5% standard deviation, which is extremely accurate.
But if you said, all right, based on our statistical analysis, there's 12% that are ineligible, then we still have to, under that scenario, still have to go higher somehow figure out who that 12% is.
Well, it's easy enough for us to, once that's identified, we can certainly go deeper. The issue would be that we didn't build that into the pricing to go to that level of detail because it may be unwarranted. We wouldn't want to build in a cost to go in and to dive in and identify individuals that may or may not be there. What we feel like we price is the ability to give you a report card and to give you the assessment of whether things are being done effectively and efficiently. And if they're not, you can use internal resources to dig into that, or you can use external resources like us. I would tell you that one of the things that was addressed earlier was the administrative function. You guys have spent tens of millions of dollars on a single consultant that's done a lot of lifting for you, but has also left your Medicaid program vulnerable to some capacity issues. So it's important for us to go in and do the analysis of the Medicaid program to make sure that the skill sets are there, that they have the ability to assume leadership and to continue to operate that program in an effective manner as that consulting contract comes to an end.
Okay, Senator Cooper, and then we've got, like I say, 3 or 4 with some generic questions. You're recognized.
Thank you, Mr. Chair. I think a lot of your presentation has been covered in this question, but this question is, please walk the task force through your cost and work plan so that we can see the work that you plan to do and how much you expect each work element to cost. The goal of this question is for us to understand how you see the scope of this project and the resources you expect to need to deliver on each piece of it.
Sure, and we can go to our plan back up on the screen to walk through that. As you said, we did cover most of the tasks, so I won't go into great detail about those, but generally we've broken this out into project management, which would include the implementation plan and ongoing attendance at the task force meetings, preparing for those and so forth. Meetings with the contract manager to make sure everyone's on track and so forth. After that, we have a series of tasks that are related to data analysis, and that would include developing the data request, formalizing the evaluation plan that we included in the proposal and so forth, and actually conducting the analysis. Next, we would develop our recommendations for both the alternative healthcare coverage model as well as the Medicaid modernization. And within those, there are a lot of tasks. There's the research, there's the conducting interviews, looking at these audit areas that we discussed, the literature reviews and so forth. We then would, and I say then, but it's kind of an ongoing parallel process, we would look at the roles of the other state agencies So in terms of the cost, we have bucketed, in terms of project management, data analysis, developing the recommendations, the report development, and the cost analysis. So our project management, which again includes preparation for the task force meetings, that's about 17% of the budget. But the bulk of our hours and budget are under the data analysis and development of the recommendations. The data analysis around 32%, and the recommendations around 30%. The report development, which would include, reviews and editing and things like that as well, taking and compiling and coordinating internally, that would be about 12%, and cost analysis is 8%.
So as I look at that, and I look at the blue boxes on the chart, it kind of looks like around October-ish into November-ish that the vast majority of the work and the cost would be expended. And then when you were talking earlier, we may discover some things where we would say either, hey, we're going to go dig deeper and do that internally, or we can hire you separately or hire someone else, of course, if you know when to do that.
You actually have folks that are doing eligibility analysis and doing a lot of these different tasks for you. As we look and if we find issues, I would offer that sometimes the contractors that you're working with should self-correct. And if we can identify the anomalies, it's up to them to show where the problems are and to offer a corrective action plan. We can come in and do all the detail. One of the neat things about us is that we don't only talk policy, we come in and do implementation. We sit beside folks, and as we're sitting beside them, we document the processes. And my colleagues don't often like the term, but we lead with a cookbook. We lead with something such that if somebody new comes in that's reasonably healthy and bright, they can figure out what they're supposed to do next. So it's empowering people to be successful versus getting our finger in the pie and pretending that we're going to stay here for 10 years.
Okay, Senator Representative Meeks, you're right, ask your question.
Thank you, Mr. Chair. My first question is, do you have any current contracts with the state of Arkansas, either through a Medicaid program, development disabilities, et cetera, et cetera? Do you have any contracts with us?
I do not have neither of our firms have a current contract. There's been discussion, as I mentioned, I expressed to a number of folks in the state that I thought you had some big liabilities with being able to tie or reconcile your federal claim. We've suggested to the Medicaid agency that we would be uniquely qualified in that I have a couple former CMS folks on staff that used to come in and audit states to do that, to reconcile some of the back quarters of the 64 report. That would not involve policy, it wouldn't involve any of the recommendations of the panel. It would simply be taking the reports that were delivered to CMS for the prior 7 quarters and making sure that the supplemental documentation that CMS would require is available to CMS so that if they come in, things are fine. If that would become prohibitive, we would be more than happy to bow out of doing that. We feel like it's completely separate from this type of work, but at this time we don't have a contract, and we would be more than happy to work with you in any manner to provide the state with the greatest level of benefit.
So you pretty much answered my follow-up, but I just want to make sure that you don't feel that doing that, or if something else came up in the next few months that would potentially be a conflict of interest with what we're doing, then you would either, like you said, you would either be willing to bow out, or if you did find that it was going to be a conflict of interest, that this healthcare task force would be the priority.
You're the priority. The legislature, the governor, the governing body, you guys are our priority. We work for you. To the degree that anything else would be cumbersome, prohibitive, even offer the appearance of conflict, if not a conflict in reality. The project, I would emphasize, the project that we're talking about is really making sure the numbers high for a very specific report that's delivered. We may be able to just do 1 or 2 quarters and train the internal staff, but historically, your Medicaid program has not gone back and done a reconciliation. They send the reports to the federal government, then they put them in a file. They don't go back 2 or 3 months later, 2 or 3 quarters later, and make sure that they have all the supporting information. What we're offering to do is to help them fix that so they can be better prepared going forward. And I would tell you that as a part of is a task force. That's one of the first things I would demand that's done. Before you look at anything innovative, creative, any way to rejuggle or redesign anything going forward, you need to make sure you can balance your checkbook. And that's what this process would do. I think it would it's going to be a quick process. It's just a month and a half, 2 months worth of work. And it would lay a better foundation upon which for you to build greater success going forward.
I have a second set of question. Basically this is around block grants and waivers. I like the fact that you put it in there, and I know some people don't like that term. And again, I don't care what we call it. Basically, it's giving the state the most flexibility with our actual healthcare dollars. Can you kind of explain some of the experience that you have with these waivers, maybe block grants, dealing with the Center for Medicaid or the Health and Human Secretary in Washington, D.C., to try to push these waivers, to try to push these innovations to give states the most flexibility with their healthcare?
I'd like for my colleagues to address the waiver issues, but I'd like to just quickly take a minute and tell you about the block grant issue. And I work with Congressman Cassidy, who's now Senator Cassidy from Louisiana, and to try and develop a block grant program, also with Orrin Hatch out of Utah, and Senator Chuck Grassley out of Iowa and his staff. The block grant program, they tried to do the block grants, and then they tried to go to a PNPN, kind of a capitated national program. I think that's what should happen. I think that giving states like Arkansas that kind of flexibility are eminently meritorious in your ability to manage your program. But the block granting of the Medicaid program in total to states, 3 years out from that. However, there are other waiver programs that are available we're dealing with on a daily basis.
Yeah, we're currently working with Alabama on their RCO model, and have been working with them directly on their 1115 conversations with CMS, helping them to flesh out their district model and so forth. And I can give you, we work with a lot of states on their waivers, whether it be 1915B, 1915C, for the home and community work-based waivers, 1115s. I can give you an example from work that I did, where we, as a first step in looking at reforms, what they were wanting to implement, and then the question came as to what authorities were needed. We actually developed the training and worked with the state to even understand what some of the different authorities are, what was required for those to town, things like that. We then assisted the state in preparation for meetings with the CMS Medicaid State Technical Assistance Team. There were 2 different programs they were looking at. CMS had a lot of back and forth as to whether what they were wanting to do required an 1115. We helped to draft the concept papers for those. Upon that review, they decided it might be 1915B, so we helped to develop the 1915B. We were still not convinced that they wouldn't go back to the 1115.